So since your body isn't producing enough for any insulin, type 1s need to replace that hormone. Insulin is a protein, a hormone. So you can't take a hormone in a pill or anything like that, but they need to inject insulin, or actually I'm using an inhaled insulin, which is a powder. But either way, I need to inject it. Most people need to inject it into their body. And so that's what you've probably already commonly seen with diabetics. Type 2 diabetes is mainly caused by lifestyle, such as lack of exercise, being overweight, diet. It can also be influenced by genetics, and if you're genetically predisposed to getting diabetes, if it runs in your family, that's another misconception. It's not always just lifestyle. So in type 2, the pancreas makes insulin, but it doesn't really work in the body, and so they can take pills for it, such as metformin is an example, and so the pills help to make the insulin that's already being produced work. And so that's why, because they're not actually giving themselves insulin, sometimes it can progress enough and they can need insulin and have to inject as well. But most type 2s take the medicine for it, the anti-diabetics, and so it helps them with that. It helps to control that. So what my doctor told me and what I've heard in our textbooks and read is kind of a lock and key analogy and picture of it. And so so the key is insulin. The lock is a cell, a muscle cell, a brain cell, any cell in your body that needs glucose, which is a preferred source of energy. So whenever you eat carbohydrates, macronutrients are carbs, protein, and fat. So carbs break down into glucose. That molecule is broken down. There's polysaccharides, disaccharides, mono. It all breaks down into glucose. And so when the glucose is in the body, it's going through the bloodstream. After you eat it, it's first digested in the mouth with those enzymes. And so once it's in your bloodstream, the insulin attaches to it. And insulin attaches, I'm not sure the specific numbers or anything like that, the ratios, but insulin carries this glucose to a cell. And so the insulin acts as the key and opens it at the receptor site and lets the glucose in, so the cell has energy and it can perform its function. So if you don't have enough insulin, such as type 1, there aren't keys to let the glucose into the cell. So there's just so much glucose in the bloodstream and nothing in the cell. So there's high blood sugar, which diabetics check all the time and frequently. So the high blood sugar, since you have that, it causes the cell, since they aren't getting that sugar, to use the other sources of energy, which aren't preferred. So they break down proteins and fats, which, this is maybe a little too deep, but fats, whenever they are broken down into your system and the blood, break down into ketones. And so when there's really high number of ketones, that makes the body acidotic, and so it changes the pH of the body, which is not good at all. So that's called diabetic ketoacidosis, because it's breaking down those fats because of the high blood sugar. It's crazy high. When patients are in DKA, diabetic ketoacidosis, their blood sugar is sky high, like 500s, 600s, some diabetics even just 300s. But and that's very life-threatening. And so the only treatment for that is insulin. So you'll see other signs and symptoms like vomiting, abdominal pain, this different type of breathing, which is trying to compensate for the acid-base imbalance. But the only thing that will actually treat it is insulin. And then you can give fluids and everything else to try to fix the problem. But so when the blood sugar is so high and the sugar can't get into the cell, it breaks down proteins and fats. Whereas with type 2, they have enough keys, they have enough insulin, but it doesn't necessarily fit into the lock. And so the medicine the pills, such as metformin, help to change that receptor site so that it can work and it can let the glucose in. It also affects different glucose absorption in the intestines and the glycogen storage in the liver. I think it has multiple functions, but so they produce enough insulin in the keys, it just doesn't necessarily work. And then sometimes if it's severe enough and it progresses enough over the years, type 2s also need to inject insulin. They're not producing as much. So that's the main points of it. So the treatment for the 2 different types for type 1 is insulin. Obviously, we need insulin every second of the day. There's different forms of insulin. I have a pen, a pre-filled pen, and so I attach the needle to it and inject it. Lots of diabetics also have a pump, which is attached to their body, on their arm, or mainly their stomach, and so that continuously gives them insulin, like a micro amount every single second, so all day long. I do multiple daily injections, MDI, so inject all the time, and so that keeps my insulin storage up where I need it. And then I also have to check it very frequently. So this is a glucometer. This is the one that I have. You'll see different variations of it, but this is the lancet I use. So there's different little needles in here that I have to rotate every single time, and then prick myself, and then the blood comes out, and there's test strips. I'll show you this. Everyone is a little bit different, and the ones that are seen in the hospital are a little different too. But so it goes in the bottom, and then you'll check it. So insulin is necessary, definitely. So that is more medical treatment of it. Some modifiable factors that you can change would be diet and exercise. So diet, we talked about the carbs breaking down to sugar, eating fewer carbs. Some people, you can choose keto or maybe even paleo, but a low carb diet helps control the blood sugar because that's putting less sugar into your body. And so for type 2s, they can take the anti-diabetic medications, and then sometimes insulin is needed if it's progressed enough. And definitely diet and exercise is a huge factor for them, since those can be the main causes of type 2. It can easily control it, and sometimes not necessarily reverse it, but they control it and manage it so well that they don't need much intervention, such as medications or insulin, anything like that. So to diagnose diabetes, you can either do a fasting blood sugar, which it's a good test. It's not as accurate as this other one. Or so you can do an A1C test, which is a blood test. The fasting blood sugar could be like a finger stick like this, or it can be blood work. And the A1C would be blood work. So A1C, hemoglobin A1C test is glycolated. I can't say the word exactly. A1C on the hemoglobin. So let me explain it. Red blood cells over time start to get sugar kind of stacked on them. And so with the A1C test, they can see how much of the glucose is on the hemoglobin, on the red blood cells. And they can measure that and see kind of your blood sugar. You can do an average blood sugar, or that translates into an A1C. And so y'all have learned that red blood cells, their lifespan is about 120 days. So that's about 4 months. So most diabetics go to see a doctor every three months. That's what I do. I think there could be some variations, but so the A1C tests about 3 months back, which is really insightful. Whereas the fasting blood sugar would be a short-term measurement of blood glucose levels, and the A1C is more of a long-term. You can see how their treatment is going, or in this case, you can diagnose them. And I think it has to be over an 8 or so. Some people are diagnosed, it's like 11. I think mine was in the 8s or 9s. But so for people with diabetes, less than 7 is good. That is controlled if your A1C is less than 7. that is really good. For a person without type 1 or type 2 diabetes, so they don't have diabetes at all, the A1C I think is around 4 to 6, usually in the 4s or 5s, but up to 6. So that just kind of puts in perspective. So there's like 4 to 6 diabetics. They want less than 7, so closer down there.